Thank you for the excellent lessons. I'm Massimo Valentino from Italy. I'm not sure to understand exactly what is your protocol for children trauma, because the most of your images were multiphasic images, and you said at the last that you don't use the multiphasic imaging. I don't understand exactly. Thank you.
Okay, what I meant is that we don't use the non-contrast phase. That's how we eliminate the multi-phase imaging. However, if we have no idea what we do because of a high-energy injury, let me rephrase. If we have no idea what potential injuries we will find, we don't have an ultrasound that shows abnormality or just shows free fluid in the abdomen. We do the arterial phase in the upper abdomen and a portal venous phase in the entire abdomen, and that is how we feel safe to exclude the pseudoaneurysms that will be missed on the only portal phase scan.
Okay, but I think that we don't know where is the possible blood problem. And so why do you limit the arterial phase only on the upper abdomen, especially because the most of the problem, especially vascular problem, are in the lower abdomen, especially from the bones of the upper abdomen?
Okay, thank you for your question. As I mentioned during the lecture, we inspect the pelvis X-ray first. So if we see any fractures, and it depends on the case. If there's no gross hematuria and you don't have a pelvic fracture, the possibility of a bladder injury is small. So we don't do the arterial phase at the lower abdomen. But if you do have an X-ray that shows pelvic fractures, or you have gross hematuria, and preferably if you have done the ultrasound yourself and you see that there is a lot of material around the bladder, then you can tailor the exam according to what you're looking for.
So you suggest to have a very tailored approach to a trauma. So you have to consider all the possible findings that you can have. Thank you.
Thank you.
Okay. Are there any other questions from the audience? Yes, please.
I just want to add a comment to the last talk, is that you asked about biphasic contrast injections. There is information on the British Society of Paediatric Radiology website about doing biphasic contrast injections, and there's actually the protocol is there. It's called the Camp Bastion Wheel, and you can get some information off there. And also, due out any time now are the new trauma guidelines from with NICE in the UK, and the British Society of Paediatric Radiology have been involved with that. And there's lots of information. So the UK-based guidelines will differ slightly from some of the European ones. For example, we're not recommending doing pelvic X-rays in trauma, because in a child who has a severely blunt abdominal trauma, we will have some information from the scout view of the CT, and then biphasic contrast injection, so you end up with only a uniphasic actual CT exam. So the UK information will differ slightly, so you will see differences.
I'd like to thank for this addition. Thank you.
Yes, please. Is it for Dr. Isaki or?
Yes, I would. No problem. My name is Vergestik Rothschild. I'm a pediatric radiologist from Vienna. Now, the title of this session is Ultrasound or CT in Pediatric Abdominal Emergencies. And I just want to ask the question, is there a role of MR imaging in pediatric abdominal emergencies? Because none of the speakers did anything about this, and according to my experience, there is a role of MR imaging.
It's a good question, but I'm wondering, is MR equipment on call for 24 hours in your department? Okay. Dr. Isaac, would you like to answer?
I think that if you are lucky enough to have MRI facilities available 24 hours a day, 7 days a week, then you need to consider MRI protocols. But I think for multi-injured children, with regard to trauma, you need to make sure that this doesn't last long, which with MRI it can last long. But I'm sure that for the acute abdomen, there are, I don't know whether the other speakers would like to comment about them. There are protocols recommended for children with different fast sequences for acute appendicitis, for example.
Would you like to make a comment, Dr. Patterson and Dr. Robin, please?
I can answer. Yes, I agree with you. If you've got MR available, trauma, I would say certainly time is of the essence. For children who have abdominal pain and acute, the definition, as Simon said, is variable depending on who it is, but certainly in cases of inflammatory bowel disease, I showed you some CT, but if you've got MR available and you've got slots, then I would say absolutely you can MR them. There's a lot of literature now coming out about patients who have acute abdominal pain due to pyelonephritis in MR. You have acute appendicitis in MR, papers coming out. So I think local expertise is really important, and availability, and sadly we have to think cost as well. So if you can put all those factors together and have access to MR and avoid radiation with CT, then yes.
I agree that if MR scan is available, a lot of indications can be replaced instead of CT by MR scan. But we have to think also that CT is performed in just a few seconds, and MR scan is time-consuming examination, and a lot of children cannot cooperate when they are in acute emergency situations with acute abdomen. They don't feel well. Dr. Robin, do you want to make a comment on this? How often do you use your MR scan in acute abdominal pain? I mean, in the emergency room.
Simon will give you the microphone. It's all right. We're not hogging it. It's all yours.
You think my male voice isn't good enough to overrule the whole. Anyhow, I think I absolutely agree, because I perform ultrasonography, and if I don't find a solution, I go to MR. So I think last year I performed less than 5 CTs of the abdomen, because you always can wait half a day, because acute isn't that acute, it's not trauma. So if you can wait a few hours for the MR to be available, and of course you need an available MR machine, and I'm fortunate position that I have. And I seldom use CT for my clinical questions. So yes, I agree, if you do have MRR at your disposal, use it. And you can, don't let you be misled by not having any protocols. Just think in a logical way and you will find the answer. Yes, thank you.
Okay, thank you. Yes, please.
May I just join the discussion in this point? I think going for MR is important not only in the abdominal emergency, in the non-traumatic part, but also the stable blunt abdominal trauma. You can do a lot. In the follow-up of trauma, you can do a lot with MR. You don't need the CT all the time. But it's our task as pediatric radiologists to make MR accessible for kids. You easily get any kind of MR machine for an adult for stroke or this and that. You have no problem getting MR slots for these kind of diseases. And we have to raise our voices and to tell them kids have the same right, and we have to have access to MR for these cases in the group of patients in the world who is the most vulnerable to radiation. And I think we shouldn't put this light under the table and say, yeah, we resort to CT because we haven't. We have to point out the finger and say, please, give us the MR, because we should no longer have to resort to CT. Thank you.
Thank you. Okay, thank you. And other questions? Are there any other questions? Okay, can I ask a question to Dr. Miller? I want to ask you, how did you deal with the fact that the son of you is classified as off-label drug in your country? I mean, how do you deal with this?
Yes, this can be a problem. The contrast medium is off-label for pediatric use, but I think that the useful of the CEUS in the traumatic patient in childhood is very important. And we in our institution, our department, we ask the parents with informed content about this use. We give many explication of the utility of CEUS that can avoid not the baseline US. CEUS can avoid a inappropriate CT scan. We use CEUS alternatively to baseline US, and patients that are negative to CEUS can be discharged without risk. Can go to home without risk. Patients that are positive to CEUS exploration actually do CT to diagnose the prognostic indicators as active bleeding, there's vascular injuries, vascular involvement of the trauma. I agree completely with my colleague that say the indication of CT. CT is indicated in major trauma. US has poor sensitivity. CEUS is indicated in minor trauma.
Okay, thank you. Other questions? Okay. So I think we can finish our session. Congratulations to all the speakers. And of course, ultrasound is the first approach, and CT is reserved when it is necessary. Thank you.